YouTube channel checked. Everything's okay.
Você quiser responder? Não, o pessoal já tá gostando já. Eu vou começar a entrar.
Yes.
Tem um delay, né? Você sabe, né?
Mas o delay tá aqui que eu tô falando.
Hã?
O delay...
Não, o delay tá aqui porque o iTunes... Tem que deixar isso aqui, ó.
Perfeito.
Senão
tá.
você vai ficar enlouquecido.
Tá. Ah, então ele tava falando em 2 canais.
Porque ele usa muita placa de vídeo.
Lizio, I just learned that I'm not able to put a backdrop like you have.
Yes.
Yes, because my computer is too old, outdated, and I cannot cope with such technology.
I thought this is a good background when you live in a desert country. It's a
Yes,
reminder of
totally. You're 100% right. Oh. And Eduardo would put the forests. There we will put the some sort of local nature.
Now,
like
I'm going to put COVID in the background because that's all in Orlando.
And Ian will put the cloudy weather.
Yes, rain.
rain.
Exactly. Yes, I've been looking for a way to do that, Lisa, and I can't find it on my Zoom.
You have to go into your settings of your own personal account.
I tried to do so, but I got a message that my computer doesn't support this kind of change. So it's okay for dealing with residents, but not for international speakers.
Oh, this computer is pretty old. I think it's now 6 years old, which, you know, for a computer is ancient.
Your computer is a baby compared to mine. How many teams do you have in Qatar League? Football Qatar League, male or female? But I don't think you have female. Have you?
No, we have very few female athletes of any sport, really. Unfortunately. Ian, do you know how many?
Yeah, I think it's 12 teams in the Division 1 and similar amount in there's 2 divisions. And they both have the same amount. And, you know, quite high performing, really. Certainly they've got some big names playing. And as you know, Xavi Hernandez from ex-Barcelona is the manager of Al Sadd, or the chief coach of Al Sadd, one of the teams here. So they do get some big names. And Mario Mandzukic was here. And Mario Mandzukic, of course, scored the winning for England in the World Cup semi-final, but he's left. He terminated his contract with the team that he came and signed for. So they get the occasional big hitter.
And the same team of Mandzukic, it's gonna be a Brazilian. He was just bought from Qatar, from the same team of Mario Mandzukic. The name of the Brazilian is Dudu. and he plays Palmeiras. I am a Palmeiras supporter, and Pedrinelli is also. So we're gonna miss him.
Not really miss.
Okay, at least
really
we're gonna
miss.
miss the goals. The goals.
Yeah. Maybe just only some sort of football he plays, but not
Yeah, but
really him.
when he wants, he plays very well.
Yes, yeah. Well, I don't know what to say about that, Eduardo. He plays well. Yes, there you go. I don't know what to say.
So
Hmm.
Listen. Are you listening to me, Lisa? I don't know.
Yes.
Yeah. Yes. You remember Jomar from Brazil that worked in hospital?
Yes, of course.
Yes. He asked me to send his best regards to you. He's working in the south of the country right now since last year.
Thank you. Thank you. Yes, he told me. Unfortunately, he's busy with the clinic at the moment. But yeah, it was about a year now, I think, since he's left.
Yes. Last July.
No, thank you very much.
Okay, I'll tell him. He'll be watching the presentation.
Will he? Oh, I got a message from him to say that he might be in a clinic, but maybe he'll watch afterwards. Yeah.
Okay.
You experienced a lot of changes in Qatar for the last 1 or 2 years, no?
There's one thing we always learn in Qatar. Everything changes.
Yeah.
Quickly
You learn patience.
or not so quickly, Liz?
Maybe daily sometimes, and then sometimes for months nothing, but eventually everything changes. So we have, I've learned many things since I've come here, but patience is one of them, and expect the unexpected. And those are valuable lessons.
Yes. But you've been there for how many years? A long time, no?
Yes, so for me, it's almost 8 years now, and Celeste is almost 10 years.
Wow.
Much longer than anticipated. We came initially for 1 year.
But it's difficult to change from one country to another. For us in Brazil, changing a country would be very hard, because if you stay out for just 1 or 2 years, and coming back will be very hard, because you lost almost all your positions and things. So
I think this is important. So when you leave, you have to know exactly why you're leaving, because usually you leave a good job, and you have to be prepared that if you lose that new job, you still feel happy that you've made the move. So for me, one of the big things was to see a new culture, experience something entirely different, have an adventure. So it didn't really matter what happened in the job. It was going to be a good move. But you're absolutely right, because, you know, as a doctor especially, it's hard. Well, you have to think about licensing, and then you have to think about, if you come back, what job will you come back to, et cetera, et cetera. But in the end, it was worth it. I've learned a lot.
Yeah, I think so. And you, Jan?
I've only been here since November, so yeah, I'm enjoying it. It's an interesting experience, as Liesl sort of says. You know, it's like everything, ups and downs, but you know, you got to get on really and try it out. You know, get the best out of it. I don't want to get to the end of my journey here and think, I should have done this or I should have done that. So that's what I'm trying to do. Ask Lisa, I'm getting on everybody's nerves. So.
No, you're not. He's the clown in the department.
Do I owe you some money, Lisa?
Now you do.
This is quite important to be happy where we are. So the job doesn't wait too much.
Yeah.
Yeah,
I have to
synchronous.
think that's one of the best things is the colleagues we're working with. We have a fantastic group
Yeah.
of people, and that makes a huge difference.
No, I'm pretty sure you have this kind of thing. So that's the same kind of thing I have with my work in the university with the residents. Even though they change every year, but they keep you green because they force you to go forward. Not sometimes you want to go backward, rest a little bit, or stay calm, but they press you, they force you, and that's a very intense experience. And from we're being since mid-March without traveling abroad because all the competitions have been canceled. Olympics, women's under 17, futsal World Cup, Copa America, a lot of things. So I would say that I enjoy very much not traveling. I could do a lot of different things that if I was abroad, I would not have the chance of having it. But this is time.
André,
Vamos lá, cavalo aí.
posso falar para eles que mudou o link?
Oi?
Pode
Porque
falar.
nós já vamos entrar. We had an unexpected issue right now. It's the YouTube link has just changed. I don't know why. They simply changed. So because this is going to be through the YouTube, they did it. So I don't know. Probably if someone clicks in the screen or in the link of YouTube, then it's going to show the new one, and then people can watch us. Otherwise, it's going to be nothing. This is so weird. I beg your pardon. Let's see. André?
Yes.
6 horas. 5 horas para você.
Yeah, well, just one moment. We got an unexpected problem with the YouTube. We're just trying to solve it. Okay, guys, let's gonna start. Como é que eu faço? Não está entrando a minha.
Estou te ouvindo.
Tá ouvindo?
I can hear you, yes.
Uhum.
Is everyone hearing André?
Não, não estou ouvindo.
Okay.
Não, eu posso começar a falar?
Pode.
Okay. So, hello everybody. Thank you very much for being with us for this educational session on women's football. I'd like to thank very much our panelists, Dr. Liesel, Dr. Jan, Dr. Dario, Professor Arnaldo. We're gonna start this first part of our journey. We're gonna have two parts. One is this Friday at 5 o'clock, and the next Friday, July 17, we have the second part with all the panelists. And I would like to introduce our co-chairman, Dr. Eduardo Stevin from Manaus, who is the team physician for Iranduba, one of our best women's team in Brazil. So please, Dr. Eduardo, make the honors. Thank you very much for all the panelists.
Thank you very much, Andrea Pedrinelli. It's a pleasure for me to be here in this webinar with Instituto de Ortopedia e Traumatologia da Universidade de São Paulo. And it's such a good to have a great meeting like this and with great topics. And so, especially when after these COVID times, we are not seeing too much football or soccer. And for us here in Manaus, not yet. We still don't have any women soccer. So, but let's talk about it because this is very important for all of us. And I'm very, this is an honor for me to introduce all the panelists. Would you like to say something else, Andrea?
No, thank you very much, Eduardo. I think we should start with Professor Arnaldo.
Okay, so Professor Arnaldo is Associate Professor of Faculty of Medicine, University of São Paulo, Department of Orthopedics. It's a pleasure to have you here.
Hi, everybody. I'd like to thank you a lot for being in this webinar. Thanks a lot, Andrea Pedrinelli and Eduardo Stevin for organizing everything, and say that without them, this would not be happening at this time. Let's go direct to the presentation. We're going to be talking about the female athlete. It's a very large and huge topic and a lot of things to say about it. I have no disclosure, especially related to the talk. Talking a little bit about the female sports, normally you mention the Olympic Games as one reference for the participation of women in sports all over the world. If you see along the years, you can see that during the last 40 years, especially, the number of women grew a lot in practicing sports. When you talk about football or soccer in the United States, since 1996, we started in the Olympic Games having the football as one official sport. In fact, it began a little bit earlier in 1992 with the World Cup, the Women's World Cup, that was the first edition. But the numbers of participants are going a lot. If you see in Brazil, during the last Olympic Games, the number of athletes were very large, very huge, and almost the same number, 1,000 of difference. And in Brazil, if you take the numbers of Brazil, you can see that it grew a lot in the last years. You can see here in the last Olympic game in Rio 2016, we had almost the same number, very near number. And if you take the American team in these Olympic Games, they had more women participating than men in the Olympic Games here in Brazil. So things that change a lot. You can see this curve, how many women are being involved with different sports, not only soccer or football. Taking the whole scenery all over the world, this is the Women's Football Association from FIFA, and it was a survey done during the last year. And you can see that most of the women participants in football are in Europe and North America and Australia. It's incredible how South America, that has a very traditional football, and especially in Brazil, football is the most important sports practice for everybody, especially men. We don't have these numbers so huge. You can see the numbers very small here in Brazil. Just the numbers of the Brazil Federation. We have 2,000, almost 2,000 women participating in official games. If you go to other countries, you have almost 100,000. So the participation of women in football here in Brazil is not so huge at this moment. But the Brazilian Confederation is working a lot, is working hard, as Pedrinelli probably you mentioned in the end of the discussion, working very hard in this to make the women football more prevalent in our society. Naturally, you have a lot of difference between men and women, males and females. If you see here in this, just a summary of some of this difference, you can see that in body composition, men has almost everything bigger than women. Here's in Portuguese, but it's weight, muscles, bones, and fat. Women only in fat have a number bigger than the males. If you go to the basal metabolic rate, women's also has a little bit less than the men, about 5 to 10%, probably because of the muscles. The basal metabolic is mainly done by the muscles. If you take the muscles from the upper limb and the lower limb, you see that, especially in the upper limb, the males have much more muscles. But if you take by volume, they have exactly the same, so very similar. If you take any other parameters to consider, like this ones here, you always see by what we call a thumb rule, you just have an idea of the numbers, about 10% of difference in almost everything. Considering the VO2 maximum, men has about 40% more than women. But if you adjust it by kilograms, it's just 20%. And if you adjust by the lean mass, it's 10%. So the difference are not so huge as it sometimes appears it is. The difference, as I told, is always about 10%. But this difference make important difference in practice and training and the injury side. We have many anatomical differences between males and females in the pelvis, in the bitrochanteric distance, the degree of inversion of the femoral neck, the valgus, the knee valgus, and the pronation in the foot. And this anatomical difference make a lot of a difference in biomechanical behavior of males and females. If you go to the knee, that is an area of great interest in sports, especially in football and in women, we see that they'll have some very known difference between the key angle, especially, and the way the patellofemoral joint behaves in men and women. This is a study from 2009 showing the different kind of injuries in different areas of the body in different sports. Here we have cross-country skiers, swimmers, long-distance runners, soccer players, everybody all together. And only you can find significant difference in this study just in some areas, like in the back for the men, like in the heel for the women, but all other differences are quite the same. All other injuries are quite the same by region and by type of injury if you consider different areas. The main difference is about the knee. Knee and ankle for the ligaments in women that have more prevalence in this kind of injury. And for men, the biggest prevalence of muscles injury. This study was done only with elite athletes. So you don't have amateur here. Maybe in amateur, it would be a little different, and maybe you have a bigger numbers in amateur because they don't have all the preparation, all the training they should have to be in practice, football especially. These are overuse injuries in this population. So we have some differences, especially sometimes for the men, sometimes for the women. But the numbers are quite the same considering all sports altogether. This is overuse injuries, the kind of tissue that is being compromised in these injuries, that there are no difference between men and women. But if you go especially for the ACL injury, and I know that this topic will be discussed in the next presentation in depth, so just an idea, just to get the point. If you see the women, they get their practice and their injuries 5 years younger than men, because they start practicing earlier, maybe, I don't know, or for the reason of maturity. Most of the women have their injuries when they are younger than 16 years old. So is this a matter of maturation? Is this a matter of strength? Is this a matter of hormonal problems? We are studying this. All the things must be involved. This is a study made in North America in the Collegiate Athletic Association. They take basketball and soccer, football. And here in football, you can see a difference in ACL injuries of almost 3 times for women. They have 3 times more injuries, ACL injuries, than the men. Why does the things happen? We have many theories, many things to explain what's going on. We have hormonal theories, hormonal explanations. We have metabolic explanations. We have anatomical explanation and biomechanical explanation. In my opinion, the biomechanical problem is the most important. The way the women deal with the movement, with the sport movement, they are very different from the men because of the anatomy and because of the muscles. In this study, more recent study from 2010 and 2015, we see that in non-contact injuries, females have much more injuries in the supporting leg and males in the kicking leg. So the dominance is almost is something very important also. So have many factors involved in the risk for these injuries. In this study from 2015, the way they do the maneuvers in football shows that the side steps have more risk than crossover cuts. So when you make the movement open the legs and the thing, when you make the movement crossing the legs, it's very different. And women normally do much more movements crossing the legs than open the legs. And the men used to do open the legs. It's a different behavior. But in both texts, and in both gender, you can see that prolonged activity increases the risk of injury, especially because it has less hip and less hip flexion. So the movement is much more stiffer than when they are not tired. They have no fatigue at all. And here we have another, it's a very, very recent research from 2018 comparing injuries in elite male and female football players alone, not all sports altogether. And we can see here by this graphic that during the pre-season period, men have more injuries and during the first competition period. And the behavior of injuries in women are more stable during these 3 periods, the pre-season, competition 1 and competition 2. And the type of injury is different also. Females have more quadricep strains and knee and ankle ligaments, especially severe injuries, and men have more hamstring strains and hip and groin injuries. So why are the things happening? The idea of this webinar is combine all this kind of theories, all these explanations, what's happening with the women, and learn a little bit more. We have many other considerations about the female athlete. Eating disorders, sleep deficit, depression and anxiety, subjective well-being. The activity scores, like Tegner score, is the same thing for different ages, different levels, and especially for different genders. We don't know, we need to study much more. But the problem the literature involves the female athlete, especially in football, they have many methodological limitations, and you don't have the same number of studies as we have in the male football. So we need to study much more, we need to go in depth in these questions as the practices, general sports and football are getting bigger and bigger during the last decade, and it will be bigger in the future. So we need to invest more money, more research, and more time taking care of the women in football. Just to finalize my presentation, I will consider some principles of training. The training principles, we have a lot of principles, but two of them are very famous and very important. Specificity, we cannot compare a swimmer and a runner, and individualization. If you take two swimmers, they are two different bodies, two different personalities. So you can't say the same thing for both. When you go to football, there's a very interesting study from 2016 comparing male and female and comparing football and futsal. They are not the same thing. The specificity is completely different. But here you see the heart rate behavior in football and in futsal. The behavior is completely different. You have different zones of heart rates in these two sports. But when you see the sex, it's completely different also. So when you talk about specificity and individualization, you must understand the gender difference. If you don't understand the gender difference, you do a lot of mistakes and you have a lot of injuries and a lot of problems in training. So this is the idea I just would like to tell, to open this meeting, and for the other panelists today and next Friday, talk in depth in different aspects of these considerations. Thank you very much for your kind attention.
Thank you very much, Professor Arnaldo. That was a great topic, and we like it very much. So this is for sure a great start. It is my pleasure to introduce Dr. Eliseo Herzema. She's consultant sports physician at Hospital Qatar, and also assistant professor of clinical medicine at Hormonal Medical College, Qatar. So okay. Yes. Now you can go, please, Eliseo. Acho que o senhor precisa clicar aqui em cima para sair.
There we go.
Here.
Can you see this?
We're good to go. We're good to go, please.
Okay. 4 years ago, a joint New Zealand-Italian team completed one of the fastest genome sequencing projects ever, taking just 2 years from beginning to end. Their goal? To document the genetic differences between apples and pears. It turns out that even though these are both fruit from the same family, they are in fact very different. They have the same number of chromosomes, but apples have more genes and more base pairs than pears. So we can now confidently say, based on scientific facts, that apples and pears are different. But then again, we didn't really need to know the genome of these fruit to know that they are different. We all know the difference between apples and pears.
Eu esperava que tivesse mais.
Sorry, I think somebody's speaker is on, their microphone.
Oi?
Andre.
Andre, your phone is on. Please, could you please switch off?
There we go.
There we go. So we also know that some things can only be made with either apples or pears. But there is a situation where apples and pears can be lumped together and it doesn't matter. And that's when you're trying to make a fruit salad. So why am I telling you this at a sports medicine webinar? Because to me, it seems that when it comes to acknowledging the difference between male and female footballers, sports medicine is closer to a fruit salad than a science. So let's go back to the science. This man was not a scientist, but 200 years ago, he made a point which has subsequently been proven by science. He said, all men are created equally. This man is a scientist, and his area of specialty is the human genome, and specifically the Y chromosome. And he confirms that human males share 99.9% of their genome. He also points out that men and women are genetically very different. Both have 23 chromosome pairs, but men have an X and a Y chromosome, and women have 2 X's. The total number of human genes are about 20,000, but the X chromosome carries more than 1,000 genes, and the Y less than 50. So there is a difference in the number of genes between men and women. There are 163 genes that are either only carried by men or carried in different doses by men and women. Also, there are 800 genes which are expressed differently based on the downstream effects of the hormones. So in essence, this means that depending on how you look at the maths, men and women have a genetic difference of between 1 and 4%. So what does this mean in real terms? Well, in the words of Prof. Page, it means that the human male is genetically as close to a chimpanzee male as it is to a human female. Think about this for a moment. We're not just talking about sexual differences here. We are talking about the fact that every cell in our bodies carry these genes, which means that every cell in our bodies have a sex. In the past, scientists used to believe that genetic differences between men and women were related to sex organs or hormones. And now they're starting to realize that the genetic makeup of the cell influences a wide variety of disease and physiological processes independent of the hormonal environment. So here are a few examples. Female lung cells have higher levels of this enzyme, which is involved in the metabolism of cigarette smoke and may cause early onset lung cancer. And indeed, women who smoke have earlier onset cancer than men who smoke. Similarly, men have different uptake of dopamine in their neurons, which may explain the high prevalence of Parkinsonism in men. And one of the most important considerations is that female liver cells have more of this cytochrome than male livers. This enzyme is responsible for the metabolism of half of the drugs we know. This means that for 50% of all drugs, the dosage requirement for women and men may be quite different. When was the last time you saw a different dosage for a man and woman on a medication label? Zolpidem is one rare example. In 2013, 20 years after initially approving the drug, the FDA recommended a lower dose for women. And the reason? It was finally acknowledged that the blood levels of the drug were almost twice as high in women compared to men. And women were more likely to be involved in car accidents the day after taking this medication. So the logical question for us as football doctors is, if men and women are that different in other areas of medicine, is it possible that they're also that different when it comes to football injuries? And the answer is probably. FIFA looked at the injury rate and type in all tournaments between 1998 and 2012. And one of their key findings was that whilst the overall injury rate may be similar, male and female footballers had different types of injuries. And this has been confirmed in other literature, as you've just heard, including this review article published 2 years ago. The most obvious differences were that female athletes were up to 3 times as likely to suffer from stress fractures, ACL ruptures, and concussions. And when they are concussed, it tends to be worse. Male athletes, on the other hand, were at a higher risk of acute shoulder dislocations and hip and groin injuries. So it seems that male and female athletes are in fact as different as apples and pears, or genetically at least, men and chimpanzees. So why did I say probably? Because we don't really know the full picture. And that is because we're not looking for it. This article was published in 2014 and highlighted the fact that women are underrepresented in sports and exercise medicine research. And a similar article published a year later found that sex-specific analysis of data in these high-impact orthopedic journals only occurred in 1/3 of all the research papers. But this phenomenon is not just limited to sports medicine or orthopedic research. The famous Baltimore longitudinal study of aging was commenced in 1958 and it still continues today. The main purpose of this study is to document the process of aging. Yet for the first 20 years, the authors only included men, even though it turns out that 95% of all people over the age of 110 alive today are women. This is Kane Tanaka, the world's oldest living person. She's 117 years old and still going strong. Imagine what she could have contributed to this interesting study if she'd fulfilled the inclusion criteria. But this one is my favorite. In 2017, a group of researchers studied the metabolism and the interactions between flibanserin, which is the female Viagra tablet, and alcohol. They enrolled 25 participants, of which 23 were men. And this is particularly unfortunate given that we know that women metabolize medications and alcohol at a different rate than men, and this medication was designed for exclusive use in women. How could you as a physician possibly take any useful information from this research? So why is this important to us in football medicine? Because of this dilemma. These are two of the world's best footballers. Imagine you're their team physician and one of them had an injury that you were not very familiar with. You want to make sure you practice the best evidence-based medicine. So what do? You consult one of these, the world's leading sports medicine journals with the highest impact factors. But here's the problem. If Messi is your patient, then this would be a very good scientific approach. However, if Megan Rapinoe is your patient, then you're in trouble. Remember, we want to be scientific, so external validity is important. And considering that we now know that men and women are about as different as men and chimpanzees, we should be looking for articles which include the group of athletes that we are looking after, and in this case, female footballers like Megan. So I've taken the liberty of looking at these three journals, arguably the world's best sports medicine journals. I reviewed all the articles over a 12-month period between May 2018 and April 2019, and the key questions were, how many original research projects in sports medicine recruited female athletes and did a subgroup analysis to report if the findings were different between men and women? And these were the findings. It turns out that if you were looking for recent research in these high-quality journals to help you with any female athlete, you'll only find 34% of articles in the BJSM or the AJSM helpful, and only 18% in sports medicine. And when you look at football medicine in particular, the situation is much worse. The AJSM may be your best bet, but still only 25% of articles will be useful. BJSM follows the 14%, and there seems to be absolutely no point in consulting sports medicine. What this means is that in case of Megan Rapinoe, consulting these journals will provide you with barely more information than consulting the American Journal of Primatology. So instead of paying attention to external validity, like we do with male footballers, we have to accept that when it comes to female footballers, most of the research we have will either only involve men or will lump men and women together, like apples and pears in a fruit salad. So as we've heard, there is one possible argument for this unequal representation of football medicine research, and that is that female footballers are a minority group. And this certainly was true in 2006 when the last FIFA Big Count was done. And a survey of all 207 member associations revealed that female players only make up 12% of the registered players worldwide. But that was then, and we know that women's football is growing exponentially. Even in this survey 14 years ago, the number of registered footballers increased by 21% in men and 54% in women. And FIFA is determined to double the number of women and girls playing in the next few years to reach 60 million by 2026. So football is now starting to follow the trend of the Olympic sports. As you've seen before, this is a graph of Olympic Games since 1900. And it looks like Tokyo 2021 is going to be the most gender equal games ever with 49% female participation. It's fair to say that women are no longer a minority group in sport. But the key message is that we cannot include women in research by assuming that they are the same as men and therefore lumping them together. Hippocrates was a very wise man when he said already almost 2,000 years ago that it's far more important to know what person the disease has than what disease the person has. So if you believe like I do that every female footballer we see, which let's face it, one day might be your daughter, deserves the same high quality evidence-based sports medicine care as male footballers, then we have to move female football medicine away from a fruit salad towards a real science the kind of science that acknowledges that apples and pears are different, and that female footballers should be treated with equal care to male footballers by acknowledging that they are not the same.
Oh, thank you very much, Dr. Rizzo, for maintaining the time. Now we're gonna go to Dr. Ian Beasley. He is consultant sports physician at Aspetar Hospital, Qatar. And I had the pleasure to meet him firstly here in Manaus during the World Cup, at the time he was the team physician of the English team. Please, it's yours. All yours, Ian.
Oh, thank you very much, and thank you very, very much for inviting me. It's a real privilege to take part in this. Just let me get myself sorted out. Hello from Doha. It's obviously been very hot here, but it's now dark here, and it's still only early evening where you guys are. And I'll get going. So the title of my talk is menstrual problems in football, I think. But you know, I thought about it, and I don't really like that title, so I changed it. And I'm going to talk about hormonal influences in women's football. And the reason I changed, sorry, I've got no potential conflict of interest, except to say I'm a big football fan, of course. And I won't be discussing any drugs at all, never mind about off-label or unapproved or anything. You know, whenever I hear about women's football, apart from Liesel's talk, it's usually about Red S and ACLs. And, you know, I'm a bit bored with it, really. So I thought I'd try and do something different. So please bear with me. I hope it works out okay. So, as you've already heard, in the women's football survey by FIFA in 2014, 30 million registered female players in the world, and the aim was to double that by 2026. And by the time everybody gets here for the Men's World Cup in 2022, FIFA's aim is that all member associations should have a women's football program. And I think we obviously all support that. And we all know that women are more likely to tear an ACL, and this is more likely to happen when the estrogen peaks within the menstrual cycle. And you know, if a woman rings me up and says to me, "Oh, I hurt my knee today, and it swelled up straight away, and I felt a pop when it went," I'm probably going to think it's an ACL, and I'm going to be right about 70 to 80% of the time, as you all know. And this is not magical science. This is common, and there's been lots of work, and there's loads of literature about this. So I'm not going to quote very much of it. So we usually talk about the bad things about the menstrual cycle, but is there any advantage that we can gain from knowing about the menstrual cycle, what happens to the hormones, and how we can exploit that? You know, what I'm after is I'm after helping an athlete to perform at their peak and be healthy. No one wants to spend time talking to me. I want athletes to do what they do best out on the field of play. So I'm asking you to consider muscles, ligaments and tendons and concussion in this short talk. Before I get to that, if I don't mention relative energy deficiency syndrome, someone will moan at me. I don't see much of it in football, but I saw lots of it when I was a Royal Ballet doctor in London. Not this particular dancer, who you may know if you're from South America. She's Marianela Nunez. She's Argentinian. She's the prima ballerina at the Royal Ballet. She's a Boca Juniors fan. And when she came to see me, I'd speak to her all the time about Boca versus River and the big Buenos Aires derby. Her dad's a policeman in Buenos Aires. He's going to get me into the Bomboniere when I go to Buenos Aires next. And according to FIFA, just under 10% of female footballers have eating disorders. So you're going to have 2, maybe 3 players in your squad that may have issues with it. And there's multifactorial sequelae from this, of course. But can we use some of this knowledge to help us, to help support our athletes and make sure that they get the best out of their career? So is estrogen good for muscle? Well, we know that after the menopause, cellular membrane and mitochondrial membrane viscosity increases and prevents glucose from getting to where it needs to be, the engine room of the cell, which is the mitochondria. And this causes more oxidant production. But if you give a postmenopausal woman estrogen, then it reverts to normal, and glucose homeostasis returns to normal, and resistance to oxidants also returns to normal. We know that estrogen maintains the strength and muscle cross-sectional area, obviously they're related, and enables regrowth with resistance to injury. So your hard training session with the micro damage that's caused to muscle is somehow mitigated if estrogen's on board. We know that muscle mass decreases after the menopause, and in fact, muscle synthesis increases after the menopause, but muscle breakdown increases even more. So the net effect is that muscle mass decreases. But again, the anabolic stimulus is regained when HRT is given. So one group of researchers, Hansen and his colleagues in 2011, found that high progesterone combined oral contraceptive has a negative impact on muscle, not something I realized. What they tried to do was give a higher estrogen pill to some women and compared it to a lower estrogen pill. The higher estrogen pill also had a higher progesterone level. And they found that it didn't make much difference from an anabolic point of view, an estrogen point of view, but it did have a negative impact on myofibrillar protein synthesis, and they blamed the progesterone for it. I'm not talking about massive doses of progesterone here, tiny doses, but has a negative impact. So the existing data suggests that endogenous estrogen increases the anabolic response to exercise, although it doesn't increase basal muscle protein synthesis. And we also know that, as we've already seen, that women suffer fewer muscle injuries during the time that they're having periods, although a fair few of that is to do with groin and hamstring muscle injuries being less. So that's muscle. Is it good for ligaments and tendons? Well, estrogen decreases ligament and tendon stiffness by preventing cross-linkage. So what's cross-linkage? Cross-linkage is a natural phenomenon and enables some stiffening and reinforcing of the tendon. And there's two ways that it happens. Lysyl oxidase affords cross-linkage in tendons and ligaments, and that's inhibited by estrogen. The other way is by a spontaneous Maillard reaction where glucose and amino acids combine to form cross-linkages. Now, this means that diabetics probably have stiffer tendons. But going back to estrogen and lysyl oxidase, during the time when the estrogen peak is happening, in other words, the pre-ovulatory phase, the lysyl oxidase is inhibited, and therefore the cross-linkage doesn't happen quite so much, at least, and therefore the tendons and ligaments become more loose and lax, and there's loads and loads and loads of stuff in the literature about ACL laxity varying with the phase of the menstrual cycle. And they've measured just about every ligament you can think of around the knee and looked at its laxity in relation to the menstrual cycle and taking blood from subjects so that they don't just look at what the patient or what the subject tells them when their cycle is, but they track it with blood levels of estrogen and progesterone, and found that with the estrogen peak, your ACL is quite a bit looser. Interestingly, there's a 20% higher risk of ACL rupture in women who've never used the oral contraceptive versus those on long-term, versus those who've used the oral contraceptive long-term, meaning that the high estrogen peak in the pre-ovulatory part of the cycle is imposes a risk on your ACL. Women have a lower risk of Achilles tendinopathy if they don't take the oral contraceptive and menstruate normally. But if you take the oral contraceptive, you have more of a normal risk of Achilles tendinopathy. So there's a take-home message from this. How can we exploit this? I always sort of feel that women get blamed for having swings in their hormones, causing them to be more susceptible to some injuries, but how can we exploit some of this? Estrogen peak is anabolic for muscles and bones, of course, as well as mitigating tendon stiffness. And it minimizes some injury risk, of course, we all know about ACLs. If the athlete drifts into red S, then no estrogen peak, increased injury susceptibility and bony stress injuries, and decreased performance. And I already said, my job in life is to help any athlete that I'm looking after to have the best performance that they can, to have the best career that they can in whatever sport they're playing. If using oral contraceptive, probably use a low progesterone one. And the best advice would be, if this is at all possible, this is a theoretical best advice, in the pre-season, don't use the oral contraceptive, so you get the best anabolic effect from the estrogen peak, and then consider using competition if necessary. But bear in mind, there's a period with when you're not taking the oral contraceptive during the time of menstruation. And the last thing is during individual rehab, if an athlete is menstruating normally without any hormonal manipulation, time the activity bearing in mind the phase of cycle. So if someone is rehabbing from an ankle sprain and you decided to do a high intensity twisting, turning, kicking the ball exercise, it's probably not a good idea to do it when they're having their estrogen peak. I just wanted to mention concussion because I think this is important too, and it's already been mentioned that it's more common. So we know it's more common in females, and the reference I've given you is the NCAA reference from 2016 from the States. And we also know that traumatic brain injury can suppress the hypothalamic pituitary-gonadal axis. That's a given, and everybody understands that. But in 2006, Davis and colleagues noted that there were better outcomes after minor traumatic brain injury in women than men, but only those who were premenarchic or postmenopausal. Now, this particular study was an ER study, not sports-related concussion necessarily, and the phase of the cycle wasn't examined. So the women who were menstruating normally, they weren't asked when their last period was. So that's in 2006. And then by 2014, Wunderle noticed that those concussed in the luteal phase had more symptoms 1 month after discharge than those injured in the follicular phase of menstruation, or similar to those taking more so than those taking the oral contraceptive. So by 2019, LaFontaine found that, or postulated really, that progesterone may infer some neuroprotection, which can be suppressed by minor traumatic brain injury when it's normally high in the luteal phase. Therefore, the brain gets deprived of the normal neuroprotection. There's a normal drop-off of progesterone just leading up to menstruation, as you know, in the late luteal phase. And so their punchline really was there was a 9-day natural susceptibility window at the end of the luteal phase of the menstrual cycle and into menstruation, where women would be much more susceptible to the effects of concussion. Now, Snook and his colleagues found that there was a higher incidence of abnormal cycles after sports-related concussion compared with musculoskeletal injuries for up to 3 cycles after the sports-related concussion. Now, we also know, don't we, that MSK injury incidence is higher for up to a year after concussion, and that's Nordstrom and Ekstrand's work, but that was 2014 in male athletes. So obviously that's something that we should be looking at as Liesel implied. And we also know that oral contraceptive users get less symptom severity than oral contraceptive users. So take home from concussion perspective, using the knowledge that we have now, menstrual status and timing, the sports physician looking after the team should always know this. And there's phone apps everywhere that tell the doc when the periods are. So the doc will know exactly what's going on. Encourage players to divulge the use of oral contraceptive and type, give advice if necessary, or seek advice if necessary. Knowing the timing of concussion with respect to the phase of the cycle may help us prognosticate, counsel player, family, and coaching staff appropriately, so that the 7 to 10 day rule that we all think, concussion, 7 to 10 days, they're usually better. If it goes beyond that and we exclude vestibular issues, perhaps we don't need to panic too much if this is what happened. And this was, they were in that 9-day window. follow-up documentation of cycle, really important, especially in view of the fact that they may be more susceptible to MSK injury for a year after concussive injury, and that with couple that with a more susceptibility to ACL injury, you may want to protect them. Advise your player, if they're not on the oral contraceptive, that menstruation may be irregular after concussion for up to 3 cycles. This is a worry if periods become irregular. So make sure you counsel them properly. Many thanks for listening, and I hope to see you in Doha. Thank you very much. There's a list of references if you want to look at them when you look at the recording. Thank you.
Well, thank you so much, Ian. And just before I introduce our next panelist, I just want to say to all the people that are watching, please send your questions. We're going to do a final round with only questions from everyone. And now we're going to shift from Qatar to USA, Orlando. It's my pleasure to introduce Dr. Iot Usp. He is the Chief of Sports Medicine at Orlando Health. He is also responsible for Orlando City Soccer Club, and for us in the women football, he's responsible for Orlando Pride, that we know in Brazil as Team of Marta. Okay, please, Dario, go on.
Thank you so much, Eduardo and Andre, for inviting me. And it's difficult to follow some of those great presentations. I'm just an orthopedic surgeon, humbly talking about ACLs. And certainly, I think the bigger picture comes into the job we're doing or the lack of the job we're doing from some of the prior presentations about really identifying the problem rather than always treating the effects of the problem downstream. So I thought today one of my interests is the ACL. Certainly, I've tried my best to navigate the ACL repair versus reconstruction kind of dialogue in the field, and wanted to give some perspectives that I had, as well as the research or lack thereof in the literature when it comes down to female football players. So ACL injuries in female football players is obviously a huge issue, as we all know. And football is a high-risk sport in general for an ACL. But in female football in particular, there are 2 to 3 times increased incidence of an ACL injury. However, when it comes to recurrent injuries, about a 4 times increased incidence. And so obviously, when a female goes down this road of tearing their ACL, often it can be a very long and arduous course. And it's our job to try to get them back on the course and hopefully be proactive in preventing the first ACL injury in general. And it's been talked about before, and Arnaldo did a great job of explaining some of the risk factors, but obviously a lot of these non-modifiable risk factors are in the patients we're talking about, which are female athletes. And certainly estrogen is another one that Ian talked about, but obviously these are things we can't necessarily change easily, especially in an elite athlete. But the modifiable risk factors are the ones that we can. And I talk about this with every one of our football players about the importance of maximizing strength, the importance of correcting neuromuscular control, and all this also working on their movement patterns, because even if great strength and great control, you don't move properly on the field and continue to put yourself in a position of at risk, especially for the ACL, you're going to eventually tear it at some point. And so ACL injury in female football, what is the gold standard? Well, everybody on this webinar likely knows that ACL reconstruction is currently the gold standard. However, we always want to continue to evaluate the differences and whether repair is an option for some of our female football players, whether they're elite or non-elite. And so currently the conundrum here, going back to what Liesl talked about, is there's really no studies evaluating reconstruction versus repair. Now, the only equitable part here is that there really aren't any in male football players as well at this point. So it really leaves me showing a picture of Marta and Alex and not being able to say much more. My presentation might be able to end here, but I won't, and I'll certainly give some perspectives that I've learned over time in terms of reconstruction and repair. And so one thing I do know, even when we talk about our so-called gold standard at this time, there's really not a perfect option. Looking at this study of female soccer players, what we've learned compared to healthy controls is they have a 5-fold higher rate of new ACL injuries, 2 to 4-fold higher rate of new knee injuries. They're more likely to quit soccer within 2 years, 62% versus 36% in healthy controls. and they in general describe a reduced activity level. And so this is the truth when it comes down to our football players, whether it's female or male. However, females obviously experience this at a greater extent. And even what was described earlier about these injuries occurring younger in females, that process starts earlier as well. And all of us probably know female soccer players that were elite that had to end their career based on having a spiral out of control occurrence after their ACL injury. And so when we look at ACL repair, there's really no research. And this is one research study that's been done by Martha Murray. And for those who don't know, she's really revolutionized a lot of the ways we think about the ACL biomechanically and scientifically. And also she's been looking at this new technique called BEAR, with bridge enhanced ACL repair. And this is the only study you can really find that's really evaluated this technique and evaluated differences between women and men. So they did a biomechanical study and looked at the BEAR technique, and the females had worse biomechanical outcomes, at least in non-humans. But as Liesl talked about, it might be useful talking about pigs if we were talking about chimpanzees too. So the difference, I don't know where the difference lies anymore. But in terms of females, they had worse biomechanical outcomes in terms of linear stiffness and increased AP laxity. And what they did know is if you are going to repair, non-absorbable sutures are better than absorbable sutures when it comes down to a technique of repair. But when it comes down to ACL repair, it's obviously had a very controversial history. And if you look at the why it's had a controversial history is because of the study constraints that came before. Only recently have we really evaluated the type of ACLs that we're repairing or reconstructing. Only recently, in the last 20 years, have we really started to revolutionize the procedure that we do and trying to make it less invasive, and also the physical therapy we do after the surgery. And so really a lot of the procedures that come and are evaluated more recently for ACL repair really got to give us a sense for success based on actually prognosing the type of ACL that we're trying to repair. And so this is some research. I don't want to go too in depth in terms of some of the current literature out there, but this is a research to show by Greg DeFelice at HSS that ACL repair can be successful. Doesn't mean it will be successful, but it can be successful. And then here's a study done by Jay Albright in Colorado that showed that ACL repair can be unsuccessful. So depending upon the variables that you use, in this study in particular, they only used one non-absorbable suture, and most people these days are using 2 to 3 to try to repair the ACL. So again, we need to be very thoughtful of the literature we're evaluating, making sure we don't throw the baby out with the bathwater, but certainly evaluating whether it can be appropriate in certain patients that we have. And so what are my thoughts on repair versus reconstruction? Well, for me, the appropriate candidate for an ACL repair is somebody who has a Sherman type 1 or type 5, which is a proximal or distal base tear. They have an acute presentation with great quality tissue and a good synovial covering of the ACL, so more vascular vascularization of the tissue we're trying to repair. And then backing it up with a suture and internal ligament brace to make sure that we don't get lift off of the footprint and give the best opportunity as possible for the ACL to heal in. The advantages of ACL repair surgery are very well known at this point. It's really less surgery and improved knee homeostasis after the surgery. Really, it's like doing a knee scope, and so these athletes are able to recover quicker. But the one problem I've run into is as they recover quicker, they like to return to activities quicker, and it's hard to hold them back. And so we really need to drill home the same physical therapy criteria that are needed to allow return to play successfully, because obviously a lot of these athletes had poor return to play analysis before they had the ACL repair or reconstruction, let alone after. The disadvantage of ACL repair that I've really come to learn are that it does have increased re-tear rates. And for me, I have a concern in elite athletes, because if you undergo this procedure and this rehabilitation once, certainly our desire in an elite athlete, it's difficult to miss 2 seasons. And so trying to do the procedure that has the least re-tear rate possible is often what you want to do to be successful. And therefore, the ACL reconstruction, it is a fantastic surgery, but there is significant need for intense PT to prevent these complications. And as I talked about before, the road for female football players doesn't always lead back to high-level sports. And so we need to be thoughtful about this and the fact that it might not be the perfect option for everybody. But the option that's most important is that decreased re-tear rate with ACL reconstruction. And so for me, even though there's no perfect option, there are concerns that come down to what type of graft you use. And so the patella tendon graft obviously has stiffness, especially in the setting of meniscus repair, and especially in the setting of female athletes. And so for me, a lot of my athletes I operated on with ACL reconstruction are young females with meniscus tears. And these are the ones with, you do a patella BTB graft that can have the most postoperative stiffness and the concern for anterior knee pain with contralation or maltracking. In terms of the hamstring, I'm not personally a great fan of this in soccer players because of hamstring weakness that can lead to increased quad dominance, resulting in the possibility for an increased ACL tear, the propensity for the possibility of hamstring strains. And then obviously this is controversial because more recently studies have been coming out showing that you don't have as much elongation and laxity of the ligament, which was previously described with soft tissue grafts. The quadriceps is becoming a very exciting option. However, we still lack a lot of the long-term data, and we lack data in football players. But I get concerned about, especially in our females, it's been talked about the increased tissue with quadriceps, but you need to be very thoughtful about not overstuffing the notch. Also, this can lead to anterior knee pain and maltracking, and the lack of long-term data, as I just described. And the only one I tell my patients I fight on is allograft in young athletes. I'm not a fan of allograft given the much higher re-tear rates that we see. And so the one thing in females to also consider is ipsilateral tears are more common in hamstrings and obviously females, so that's why that's not a great option for me, especially in those that tend to hyperextend. So what is my algorithm then? So in pediatric patients, I think these are the best ones. When I have to worry about a growth plate, if I can repair and do less damage around the physis, especially in those prepubescent patients, then a repair is a great option. Otherwise, I like to use a soft tissue graft where I avoid growth plates. In the adult athlete and a professional, patella BTB autograft is my go-to as well in college athletes. In high school athletes, I'll have a long conversation about how elite they are and how much, if it is a repairable type of ACL tear, whether a repair is the right option. But if they're an elite athlete that plans to go on to play competitively, then a patella BTB autograft is usually the one that I'll recommend. And then recreational athletes, I'll tend to move to more of a repair than the patella tendon graft if it is repairable with a true proximal avulsion or distal avulsion type tear. So the most important thing that I talk about, and this has been talked about a few times today, is that to me, ACL surgery, I think we have great options. The problem and the re-tear rates that we see are probably because of the lack of attention that's paid to the postoperative setting and really putting our athletes in the best hands possible with the best physical therapy that they can have to prevent another ACL injury. And so for me, return to play criteria is time and criteria based. For me, I wait at least 9 months to return to play, even if the return to play criteria are rarely met. We usually still hold off because the graft incorporation is usually the best by 9 months. I want to see that they're hitting their subjective and objective scores. For me, psychological scores are extremely important, especially in our young females. This can be a very devastating injury with a long time out of play, and I think a lot of times it's becoming more known about this psychological component, but we need to pay more attention to it. Now, for me also, once they so-called pass their tests, to me, there's a transition to play program, which I increase their sport-specific movements. I have them take video, even if they're not elite athletes with our teams. I want to evaluate, do their mechanics break down with non-contact and contact? As we move from predictable to unpredictable, I want to make sure their movement pattern stays the same. And this includes in their transition to fitness program when they're increasing their minutes. As they get tired, do they still maintain quality movement? These are some of the tools that we're using. We use the Noroxon equipment, and what we're able to evaluate is how they do in the clinic with the eyes open and their single leg hop, which you'll notice when their eyes are closed. And they have more unpredictability to their movement pattern. It simulates this, that they can have a breakdown in their mechanics with their single leg squat. And when you add contact, sometimes that contact will change how they perceive and how they actually use their single leg squat and how much they trust their muscles to work for them rather than against them. And again, this Noroxon equipment's been great. One other thing we've been doing in our area is this spring-loaded brace, and we did a research study on it showing that it can increase posterior chain activation and decrease quadriceps dominance and decreased hyperextension tendency in our athletes. We've been using this early on in our postoperative setting to try to get the athletes to rely on more of the posterior chain to help them, because I think this is a huge problem that we really battle in the postoperative setting. And I found that this spring-loaded brace can help with that. So something worth a try if you're having these problems in your athletes as well. So thank you very much. I'll turn it back to Eduardo.
Thank you very much, Dario. It was great to have you here. And for me, there was a great webinar. I thank you all the panelists. I'm going to give now, from now, I'm going to give the word to Andrea Pedrinelli. I believe he has some questions that he received. And it was really amazing for me to be here and hear all the topics we had today. Thank you so much, and hope to see you soon, all of you. Although the COVID-19 doesn't help us too much, but thank you so much for the people from Qatar. Have a good night, and likewise you there in Orlando. The same time that I am in Manaus. Thank you so much. Andrea, it's yours, please. It's your
Many
time.
thanks, Eduardo. I would like again to thank you very much for our panelists. We had at least 300 people seeing us, so this is a quite trend topic, women's football. And I would start with a question for all the panelists. I would say just 1 minute for everyone, saying how you conduct your preventive program in the setup of your athletes concerning women's football. As we're Latins, we're going to start by Liesl. So Liesl, please start answering, please.
Thank you very much, Andre. You know, this is a bit of a tricky question for me because in Qatar, we don't really have that many female football players. So it's difficult for me to answer that question, but my sister and I have just done a survey amongst elite athletes participating in the Football World Cup, the last Football World Cup in 2019, to see what is the attitudes, the beliefs, and also the practice of implementing injury prevention programs amongst these teams, not at the national level, but at the club level. And it was really interesting to see that actually the knowledge of what kind of injuries they are susceptible to and also the attitudes are very positive. But many of these teams do not have a lot of access to the right sort of people to be able to implement these programs. So I know I haven't really answered your question because I haven't talked about Qatar, but I think there is a big problem out there in that women are very keen to implement these programs, but they don't have a lot of access.
Many thanks, Liesl. Arnaldo, please.
Okay, it's a matter of discussion. We have many different programs about prevention, and some of them are reporting different papers that they are good enough, like FIFA 11 plus. But the main idea is to make the movement of the females be more equal of the movement of the males about the knee and the ankle, because what we know that they have more injuries in ligaments, in knee and ankle, different from the men that have strained injuries. If you do a preparation that give more strength to the movement and correct the pattern of movement, because they have a tendency to make adduction of the hip and the valgus, or the dynamic valgus, trying to diminish this and training the core. That's a very important part of the training of the women. We can get some benefits, but you need to take the athletes who were mentioned in different talks in many ways. You're talking about anxiety, sleep, alimentary behavior, and many things. But I think the biomechanic teaching and training and taking care of the core and the movements of the lower limb is the most important thing. Indeed.
Many thanks, Arnaldo. Jan, your comments?
Oh, thank you very much. Yeah, I agree with Liesl. Resources are all actually in sport. If you've got resources, then you can do a lot. But basically, this is an education program, and it's an education program for the athlete, but also for the staff surrounding the athlete. So you've got to make sure that people understand exactly what's going on with the athlete. As I talked about in my small talk, understanding what happens with the hormonal cycle, understanding what happens physically and emotionally, psychologically with the athlete. And that means that you've got to have a team around the athlete and the team to make sure that they can deliver things properly. And that takes resources or energy.
Thanks, Jan. Dario, please.
Yeah, so for me, it's probably responsibility and accountability, establishing who's responsible and then holding them accountable. And so in the US, we have athletic trainers that typically will provide the care and be the kind of the glue that holds the entire team together from a medical perspective in the locker room. And so we try to make sure that the teams that we do have our athletic trainers with, that they're the ones that are responsible to make sure we're building the FIFA 11 prevention program or other programs to be able to help prevent injuries. And then that's able to establish our accountability. The problem comes in our country is that for most of our athletes, and especially when we're talking about our female football players and the age that they're typically tearing their ACL, which is probably under 19, so they're not in college, they're either in high school or they're playing recreational or they're playing for a travel team which doesn't have an athletic trainer, that we rely on the coaches. And so in my experience, that's been very difficult because it's hard for the coaches to really understand how to make sure that they're evaluating the quality of the FIFA 11 plus prevention program that the athletes are doing. So I think those have been the concerns that I've seen, and I think that's what's going to have to change to establish responsibility for people in those settings that will take that responsibility and go with it. Typically, I have found it's either the star player needs to get hurt or the coach's son or daughter for them to actually start rolling out the FIFA 11 plus prevention program or anything else. And so in those situations, I've been very successful. Unfortunately, again, reactive, not proactive.
Perfect, Dario. As we are settled in an orthopedic institution, we have quite a few orthopedic questions. So I will start addressing with you, Dario. Is there any place for extra-articular, mainly concerning anterolateral tenodesis or extra-articular procedures when you consider an ACL reconstruction?
I tend to be, I tend to live in the middle, and I'm somewhat of, I know the debate has come up about lateral extra-articular reconstructions, and I think there is definitely a place to have them in our athletes. Obviously, people that hyperextend, recurrent tears, chronic tears. To me, where I still see that big pivot shift, and people where I think the extra-articular soft tissues laterally have kind of attenuated and need addressing, is usually those chronic or revision situations. I think often, in my opinion, they can often heal in the acute setting if you treat ACLs sooner. And I think the data out there is that there is concern just as much for overloading the lateral compartment as it is for does it prevent an ACL injury. And so there was a recent study that talked about that as well. So I still think it's the final decision is out there in our female football players. I think the hyperextenders, there's a concern, and those might be people that could be good candidates to add a lateral extra-articular reconstruction.
Thank you, Dario. Lisa, a lot of people are questioning me because you told that we should differentiate prescriptions amongst women and male. And is this a regular setting in your practice that you adapt medication or prescription of medication to your athletes?
No, I don't, because there isn't actually any enough research to tell me what it should be. And I think this has been the problem historically is drug manufacturers were careful not to include women in their studies because of the potential that they might get pregnant or be pregnant. And so they've been largely excluded from drug research. But of course, the problem with that is then you really have this one group of people and you're extrapolating to other groups. And we're only talking about sex here, but you could probably extrapolate this and include race as well. And you can also flip it around and say, now that we are including more women in studies, maybe not so much drug research, if you don't actually report the results and differentiate by sex, then you're also getting women included in the research that you're applying to men, but you don't know what the influence of the women are on the overall results. So essentially, if you're mixing apples and pears, then you can't really be 100% sure what you're telling apples or pears. And this is the problem we have.
Yeah, that's some sort of thing that we might think on the future about this. And Ian, a very specific question. You talk a lot of difference in the cycles and phases of the cycles of women's cycles. Would you change training patterns due to cycles?
Yeah, it's a good question. And the short answer is yes, and the long answer is no. I mean, I think I sort of intimated that when I talked about having an individual rehabilitation. So if the athletic trainer or the physio is out on the pitch rehabilitating a player, you take that into account. The real problem is when you've got a squad of players, it's very, very difficult to individualize. I mean, I think it would be great if you could, and there are going to be phases of the season, perhaps pre-season, when you can do that. But it's going to be very, very difficult. So I think it's a bit like the drug thing. It'd be great if we had all the information and we could do that, but you can't really train defense versus attack with just 2 players. So I think practically impossible. Be great if we could.
Very, very interesting. We have a question that might not be well concerned about what our topics, but we have a guy that asking if you do know or you do use some sort of medication that enhances muscular injury rehabilitation. It's open to all the panelists. Who's gonna be the first?
I can say, no, I don't. No, I don't. Because you have a natural history of scar formation and cicatrization. So it's much more important to do a good rehabilitation and a safe rehabilitation than trying to find some magical drug that will make the rehabilitation and the muscle injuries really faster. Maybe in the future with the basic studies in mesenchymal cells, something like that can happen. But in practice nowadays, I think you do the regular rehabilitation and treatment. This is my position.
Sorry, no, go ahead.
Ian, go ahead.
I agree. I think first 48 hours, no anti-inflammatories. We all know that now. But look, you're right. Proper rehabilitation is what will do it. The real problem is it's fine when you're talking about elites, when they have access to good treatment, good athletic training, good rehabilitation. Most people don't have that access to it. Most people are told by an emergency room to go home and rest. It will be all right in 3 weeks. That's really not the right advice. So if everyone had good rehabilitation, they wouldn't need any drugs.
Yeah, I agree. We have a discrepancy, and we all try to provide elite level care for all of our patients. But the reality is that that's dependent upon insurance in some areas, and it's also dependent upon the athlete's ability to obtain that care. And so for me, I think the only thing we do in elite athletes from a medication perspective is sometimes use platelet-rich plasma. Occasionally, we have that discussion in the U.S. It's used a lot on grade 2 or higher musculotendinous injuries. And so occasionally we'll use it, but we don't necessarily push it with our athletes. We have a discussion with them, and we go through risks and benefits, positives, negatives, and help make the choice together.
Then we'll have, I would say, our final question to the time table that we have from here to Qatar. And what concerns the difference between males and female? We're gonna forget chimpanzees and other sort of animals. What do you advise? It's a good age for to start practicing competitive sports in the women's one set?
I'll go with this one first. That's a great question. I have a daughter who's 10 years old that's playing soccer, and the hard part is you have to get them involved in soccer or in sports at a young age, just to build that love for the game. And so I think that becomes the culture for the athlete. The hardest part is, how do we get our youth athletes to play different sports? I think almost all research has shown sports specialization at a younger age will be more likely to lead to injuries later on, just given that our athletes don't tend to become athletes. They become football players in this case. And so I think we need to do a better job of making sure our athletes are playing multiple sports, learn to use their bodies in a multitude of different ways, so they develop movement patterns that are successful and will withstand the test of time and hopefully help prevent injuries. So not the better question, but another question is, when do we start the prevention programs as well? And so I think in our young women, I think 10 to 12 is probably that age. It's like we've learned in America, when do you have to teach people not to smoke? It's 5th grade. And so I think it's the same thing for our youth athletes, especially if they're sports specializing.
André?
Go ahead.
Okay, my consideration about it, it's very difficult to say that. We have different kind of sports. If you go to Olympic gymnastics, swimming and football are very different. We're talking about different things and different risks. But if you're talking about football, that's this webinar central discussion, I think you should wait a little bit more than 12 or 14, because the risk for women to get injured at this age is very high. So during this time, they should be doing different kind of sports and not only football. And about 14 and more, they can go to competitive. But we need to know that competitive sports is a matter of wish. I wish to do this. This is important for me. And at this age, most times it's important for the parents and the coaches, and not for the children, in fact. So we need to take care and see and verify if the child really wants to do that, because any competitive sport, especially football, has a risk. It's different from physical activity to be healthy. So we need to consider and explain the risk.
Lisa, I want to hear your thoughts.
Lisa, after you, Lisa, please.
So I'm not talking about competitive sport. I think for me, a very important message would be to encourage young girls to think about any sport as something which is available to them. That there's none of this men's sport and women's sport. Anything is possible. And I think if you get young girls involved at an early age, but not on a specialist level, just in an interest level, that for me, that's more important than worrying about when you should start specializing.
And I agree with that. And I think that what you're trying to do really is you're trying to develop a person. You're not trying to develop a sports person. You know, I've been involved in academies of professional clubs when everyone wants to win. It's not about winning. You know, even at professional clubs, hardly anybody makes it into the first team. It's about developing a young person. And I don't care about whether they're male or female. It's about developing a young person and giving them some sort of start and letting them understand where they are in the scheme of things. You've got to protect them, of course you have. And I have lots of discussions with people around other professional teams that they want to do things like treat young players, 15-year-olds, by injecting them. And I always say to them, if they're injured, you leave them, you treat them, you don't do anything to them. You've got to protect them.
Perfect. Thank you very much, all the guys. I would apologize for our audience. There's still a lot of questions, but we had 1 hour and a half of discussing women's football. I think it's quite a long time. So I would thank you, and thank you again for all our panelists. It was of a very great quality, and you could show us your expertise in this field of knowledge. So I will finalize here and open to the panel for just your final remarks.
starting by the boss, your boss. I'm a close friend of him. Just I'm joking, okay? I didn't tell, but during my presentation, I presented a photo of Sport Clube Corinthians in Brazil. That's the most important football team. Pedrinelli does not agree. And as I told you, competitive sports, especially football or soccer, is something that have a lot of risk. So you should be very well prepared. But unfortunately, we have many kids, 6, 7, 8 years old, practicing a lot of football because their parents want to have someone famous in the family, maybe, I don't know. And you need to take care because it's not our function. As a doctor, you need to take care of people and not make champions. Maybe for the coaches, it's more important. I don't know.
Okay, thank you very much for your guys. We're gonna finish this. Take care in this different times we're experiencing our lives, and see you soon the next week. Thank you very much. Bye bye.
Thank you.
Thank you.
Thank you.
Thank you.